Chapter 12, Information Technology. Paper medical records switching over to electronic health records. EHRs typically support care planning, order entry and management, and communication. So moving from paper medical records to electronic health records allows patient-level data to be aggregated to create a picture of the population, their care, and the outcomes of care. EHRs are essential for managing population health, improving quality, and reducing overall costs. Promoting effective use of IT is a key area of focus for U.S. health policy and health reform. So now we're going to talk about the importance of structured data. There are two key aspects. Discrete field or data element for each concept, and then also the standard code set, which is controlled vocabulary for expressing the data in each field. Structured data are computable. Computers can apply clinical decision support algorithms, such as drug interactions and allergies, and also less risk of misinterpretation by humans. Because they can be used directly by computerized clinical decision support algorithms, structured data are computable. And then semantic interoperability. Semantic is a study of meaning. Two systems exchanging a scanned note are interoperable, but they are not semantically interoperable. If they exchange a code allergy list using a common coding system, then they would be. Administrative data versus clinical data. Administrative data, which are like claims data, typically insurance claims or bills. They provide information on service provided, not the outcome, such as lab test or diagnostic procedure performed, and they do not include care coordination, patient outreach, or education. Now, administrative data, they provide a useful view of the care process. They have an advantage of being structured with discrete fields and common codes set for the patient's diagnosis, services provided, and procedures performed. And also, they reflect all covered services that a patient received from any provider. And then on the clinical data, this is where EHRs allow for more clinical data to be shared, such as lab results and physician findings. Clinical data also enables patients and providers a more robust view of the health of a patient or population. And then also, too, its limited ability to transfer data between provider networks. So where historically recorded in unstructured form due to paper records, now clinical data can be associated with electronic health records. So EHRs allowed this data to be recorded in a structured form. So now let's talk about the incentives for electronic health records adoption. So cloud-based systems and federal incentives have enabled smaller practices to actually implement EHRs in practice management systems. In 2009, Congress authorized CMS to provide financial incentives up to about $44,000 per physician for practices and hospitals that achieve meaningful use of the electronic health records. Incentives began in 2012 with the first three stages of requirements. By 2014, 53% of physicians had received at least one incentive payment. When this first came out, few small practices have had the time or money to undertake a disruptive IT implementation. Plus, small practices had limited potential to gain efficiencies through workflow designs. So using population-level analytics for improvement, here we have a process redesign. Here is where you improve performance or care, reducing the cost for the typical patient. You're going to reduce variation, which leads to better outcomes. And then also you're going to have better care coordination. Now, care coordination will ensure that all patients receive consistent, complete, and timely care. Exception management. This will identify potential outliers for individualized attention, and then also to help along with case management. Now, case management is tailored to individual needs for complex patients, such as telehealth to monitor weight for CHF patients or something along those lines. And then also the Pareto principle, which is the 80-20 rule. Here, 20% of people consume 80% of the total medical costs. And then even within this group, 5% of people consume 50% of the costs. The important theme in managing population health is using data to identify people who have needs and then reaching out proactively to them to ensure that their needs are met. So along the lines of mobile health and social media, technology is rapidly changing the way care is delivered and received. Patients are able to measure a variety of clinical parameters on their own and communicate with the clinicians. Patient portals allow for patients and family members to participate in patient care, as does telemedicine, and providers can obtain health risk factors. And also the demand grows as the baby boomers age. So IT systems within an organization include three major categories: transaction systems, population management systems, as well as data warehouses and analytics. These categories are distinguished by the business functions they support and the level of data aggregation or bring together. Transaction and population management systems are used concurrently to support operations, and then data warehouses are generally retrospective. Transaction systems generally focus on the individual patient. Population management and data warehouse aggregate data from patients within a provider's organization's population. And then Health Level 7, which is a messaging standard that is most often used to transmit orders and results among different systems within a provider organization. So now we're going to discuss creating data warehouses. Data-driven analysis within and across provider organizations. These should include exploratory analysis of data, which will allow for population-level analysis. Ontology, which is a hierarchy of concepts. These provide a name for concepts within a certain domain and defines relationships among the concepts. So this will enable asking questions at any level of the hierarchy. Example, was the patient on a beta blocker, without having to specify the list of all beta blockers. Data warehouses are any database that aggregates and organizes data from multiple source systems, that has a defined process for keeping it current, and offers the ability to query the system in ways that were not anticipated when the warehouse was designed. So aggregation of patient data are longitudinal records, which follow an individual patient over time. Only over time can a full picture of a patient's clinical condition be appreciated as a patient receives care for different conditions. And this also integrates records from multiple providers. Episodes of illnesses, an algorithm using longitudinal data to distinguish acute episodes from ongoing care such as chronic conditions. So enabling data-driven improvement. Here we have provider organizations, individual providers, and P4P programs. The P4P stands for pay for performance. They are evaluated on patient outcomes. And they're also graded on how consistently they follow accepted guidelines for treating a certain condition and the patient outcomes. Many factors other than quality of care can influence outcomes, such as lifestyles, level of education, as well as socioeconomic status. So risk adjustment. So without credible risk adjustment, providers may be reluctant to accept high-risk patients, which can create a barrier to access for the sickest population. So these risk adjustments, they account for patients' factors associated with the greater risk of certain outcomes, and also it's critical for published provider report cards used as a basis for payment. And then clinical administrative data used for PI and research. Number one, they make extensive use of system-wide clinical and administrative data for performance improvement and research. They have established voluntary data sharing programs for benchmarking and collaborative shared learning. And then also it includes provider-oriented clinical data research networks and patient-powered research networks. Talking a little bit about now health information exchanges, or HIEs. It's an interoperable health information network, which are usually made up of state or regional health information exchanges. The providers and patients can access and securely share patients' vital medical information electronically. So it's meant to improve speed, quality, safety, and cost of care. It's governed by the Office of National Coordination of Health Information Technology, or the ONC, and it's currently operated by local, state, and regional organizations. It's a Blue Button initiative. So Blue Button Initiative is a set of standards designed to allow patients to access their health information held by providers, payers, and government agencies. Medicare beneficiaries have access to their claim data, and patients of the Veterans Health Administration can use the My Healthy Vet portal. And then also some challenges are technology and culture. So it's hard to achieve effective care coordination in our fragmented health system. For example, just for the Medicare patient of a typical primary care physician, there are 229 other physicians working in 117 practices and with whom care must be coordinated. So it's unrealistic to expect that simply connecting EHRs, even though a sophisticated HIE will cause independent physician practices to immediately become medical homes. Also need predictive analytics, shared protocols, and highly trained clinical personnel to provide care case management for complex patients. So under public health informatics, applied epidemiology is the foundation of public health. So here, public health informatics, they understand patterns of disease and needs for health services, including prevention, for an entire population. The population view in a provider or payer database is usually a patient or beneficiary population, not the entire population. And then also, too, it relies heavily on survey data from a census or from the CDC. And then surveillance is an important function. Number one, for under surveillance, which is an important function, which providers are required by various state laws to report real-time data shared by emergency departments. That's for reportable diseases. For the health information exchanges allows for more effective surveillance. Here, providing data that are both broader and richer than those currently available. And then for the last one, active surveillance for detecting, understanding, and preventing adverse effects of drugs and biologic products. Since clinical trials only use a few thousand patients at most, uncommon side effects and adverse reactions may not be known when a drug enters the market. This helps to get that information out there. So, big data. It's used for more than building warehouses and collecting known data sets. It also collects data from diverse sources without mapping. It's automated knowledge discovery. So it'll identify empirical relationships in the data. Its goal is to still distinguish signal from noise. So noise may be dominant and signals difficult to detect. And then also it also identifies genetic variants that predispose to certain diseases. However, use of these methods in a context as complex as healthcare delivery and population health is pretty new. Now, under the cognitive systems, you have the genomic profile, you have the IBM Watson, natural language processing, as well as the future of clinical decision support. So here, routine medical care is beginning to exceed the limits of human cognition. More than 5,000 new articles published in the peer-reviewed medical literature every weekday. So it's especially true in the areas like oncology. So under the genomic profile, it's the set of general or genetic markers present in a given patient. These markers help to show if a person is susceptible to a certain disease or how they will respond to a certain therapy. And then we have IBM Watson, which simulates information from unstructured data sources ranging from Wikipedia to papers published in peer-reviewed journals and develops a semantic network. And also, too, the natural language processing. It infers concepts from free text and accommodates conflicting and updated information, recognizing gradation in levels of confidence and applying evidence-based reasoning techniques to answer questions. And of course, for the future, current uses of Watson are limited, but it offers a glimpse into the future of clinical decision support. IT implementation, process redesign, and cognitive support. IT currently consumes 25 to 35% of hospital capital budgets. So the importance of process redesign and cognitive support include clinical and operational leaders. Support is critical for successful EHR implementation. Redesign the care process to take advantage of IT, so recognize efficiencies and improvements in quality and safety. Also, create a communication channel to avoid alert fatigue. So in other words, you're getting too many trivial alerts, reminders from an EHR. Important alerts are being ignored or missed because they're getting too many trivial ones. Or capturing structured data in an EHR allows alerts to be fine-tuned for appropriateness. So culture eats strategy for lunch. So no matter what business strategy or strategic plan you try to implement with your team, its success and efficacy are going to be held back by those people implementing the plan. So also we want to create standard protocols and decision support rules or tools. It's normal for physicians within a practice to take different approaches for treating certain conditions, but this isn't recognized when using paper records. By creating these protocols and decision support rules or tools helps to bring this issue to light. And then to view the EHR transition as part of a fundamental transformation in practice. Here, implementing an EHR should not be viewed as a technology project, but as a strategic change management initiative. In conclusion, the adoption of IT will enable better decision-making and caring for individuals in managing population health. EHRs and registries play an essential role in implementing what is learned from data warehouses and improvement initiatives. Healthcare is on the threshold of another dramatic change enabled by IT. Over the next decade, the availability of genetic information will add a highly personalized approach to preventing, diagnosing, and treating a variety of health conditions. And then also, too, telemedicine will continue to transform traditional care delivery. So that concludes Chapter 12. If you have any questions, please feel free to let me know. Thank you.